let's move on to perhaps a more common clinical scenario of giving chemotherapy to treatment-naive patients with advanced squamous cell lung cancer, and potentially talking about the optimal chemo regimen. So I look at chemotherapy regimens for squamous cell as a story of competing standards, really. We have the cisplatin gemcitabine regimen that emerged out of the Scagliotti data, very large study randomizing patients to cisplatin gemcitabine versus cisplatin pemetrexed. It included both adeno and squamous cell patients, and we saw in the subset of patients with squamous cell, which I think were around 450 patients, we saw a benefit with cisplatin gemcitabine in survival over cisplatin pemetrexed, and we saw obviously just the opposite for patients with non-squamous. There seemed to be a preferential activity of cis-pemetrexed over cis-gem in the non-squamous population. So we have cisplatin gemcitabine from that data. We've got carbotaxol hanging on as still a competitive regimen, I think, sometimes often in the community, but perhaps in academic centers as well. The carbotaxol data emerging out of the ECOG 1594 study showing relative equivalence to other platinum-based regimens with perhaps better tolerability, and of course that study included squamous cell patients as well. And then more recently, we've had carbo-nab-paclitaxel, or carbo-Abraxane, come out and having some very competitive and compelling data. This was a large phase 3 study of more than 1,000 patients randomized 1-to-1 to carboplatin solvent-based paclitaxel versus carboplatin nab-paclitaxel. In the intention to treat population, and this study included both adeno and squam, in the intention to treat population, there was a response rate advantage with carbo-nab-paclitaxel. But interestingly, in the subset of patients with squamous cell, we saw that this benefit was more pronounced in response rate. We saw a response rate in the subset of squamous cells of 41% versus 24% in the carboplatin paclitaxel arm. There was a non-significant trend in overall survival in the squamous cell population with carboplatin nab-paclitaxel versus carboplatin Taxol. And importantly, also the AE seemed to be a little more favorable in the carbo-Abraxane arm. There was less neuropathy, obviously, less neutropenia, less myalgias and arthralgias, but more neutropenia, more anemia and thrombocytopenia. So this data has clearly come out and changed the way that we may treat patients with squamous cell. Interestingly, in that study also, the subset of patients over the age of 70, for reasons that I'm still trying to grapple with, had a survival advantage. We have to be cautious with subset analyses, but there was a subset analysis done on the patients over the age of 70 that showed a survival advantage with carbo-Abraxane over carbo-paclitaxel. So we've got cisgem, we've got carboplatin paclitaxel, and we have carbo-Abraxane. So I'll just open this up, and maybe we can start with Ed. Your impressions of the data. Is there an optimal chemotherapy regimen based on what we have, and what are you using and why?
Okay, everybody get a comfortable position. I'm going to break it down right now. So, I always like to look at things we report on, and then if you were to design a similar study, what would you do differently? And it's like looking at it forward and backwards. So the Scagliotti study of gem-cis versus pemetrexed-cis was a very logical study to design at the time. It was in both histologies, non-squamous and squamous. Gem-cis was going off patent in Europe, and Eli Lilly needed another regimen to replace it. And we all know pemetrexed-based regimens are really phenomenal. I mean, that's one of the few cytotoxics that's really changed a paradigm, a treatment paradigm clinically for people in their maintenance setting, second-line setting, and first-line setting. But it also changed the paradigm in that it doesn't work in squamous. Yeah. And in fact, conglomerating the data, it's actually harmful in squamous. And so for me to even state that gem-cis came out any type of winner in that trial is not correct.
So you think cis-pem is such an inferior regimen in that patient population? It's hard for cis-gem not to show a preferential activity versus cis-pem.
Sort of like trying to boost my ego on how fast I may be and getting my 10-year-old out on the track and beating him. I'm like, yeah, I did it. You know, maybe have maybe a year or two left of this. So it doesn't speak that I'm fast. It speaks to him that he's slow.
Okay.
And so the numbers for GEM-CIS were very similar in the survival in both the squamous and the non-squamous, and they were both about 10 to 10 and a half to the high 10 months. So to me, to sort of de facto say that GEM-CIS is all of a sudden a great drug for squamous is a misnomer, and I don't like when I hear that. Talking about the Taxol aspect, the carboplatin paclitaxel, yes, it is amazing. That drug has stuck around for ages, isn't it? And your comment was there's a lot in the community. Let's not forget Dr. Schiller and a lot of these thought leaders designed this study, Dr. Bolani, Dr. Schiller, and so these are academic thought leaders who designed these studies, reported them at ASCO, presented them, in high-profile journals, and so, I would say that, the example was set from the top and has permeated through the bottom. Now, favorable reimbursement, favorable other things have certainly perpetuated that. I fight the same battle. I feel the exact same way. I don't know why this drug continues to be used so often when we have these other alternatives, but it speaks to the fact that people still see very adequate, tolerable side effects and activity. And so when you come to